So some of the, there's common themes, and we actually didn't discuss these things before we got in here, but some points that are worth running over anyway. Many of you may not know, Medicaid is the third largest payer for health care in the country. And that being the case, it always garners a great deal of attention. If you really look at it in the side, if Medicaid nationally was a country, it would be somewhere between Norway and Austria as far as the size of an economic power that is. So when you're starting to talk about $495 billion, it's something that could afford some great deal of attention, and how to ensure that it doesn't consume more of the funding for other vital programs. So as we think about Medicaid, though, and I think what they were doing in Maryland is spot on. You can't look at these programs myopically. If you look just at Medicaid and make decisions in Medicaid, not recognize what's going on in the commercial space or in the qualified health plans or in Medicare, your policy decisions may not necessarily hit the mark that you were intending to. Looking at Medicaid, and yes, anybody that likes to add up numbers on graphs to see if it all adds up, it won't, because I didn't list every service Medicaid does, but just to give you a bit of a flavor, Medicaid pays for about 17% of the hospital care in the country, 8% of professional services. Nursing home care, no surprise, Medicaid is the largest payer in the country. Prescription drugs, 8%. Typically Medicaid, other than like in nursing home care, is typically, again, the third largest payer of these services. In Tennessee, not very different. We do a lot for our nearly 1.5 million residents. You look at over $2.5 million therapy visits for the mentally ill. Over 2 million prescriptions. We're a high prescribing state, so that may not translate well in other states. Over 2 million outpatient visits, 700,000 plus inpatient stays. Now, a little bit about Tennessee, just so we can orient everyone to it. As I'm talking today, I'm not talking as if we've solved every problem that's out there, but we do have an interesting history, and I often describe it as a tale of 2 decades. The first decade, we have perfected how not to do things, and the second decade, we try to learn from those painful mistakes. And I'm happy to tell you, I think our outcomes have indicated that we've made some great strides. And what this is pointing out is a variety of our quality measures. We've seen over 85% of our quality measures improve since 2007. Our patient satisfaction has reached an all-time high of 95% 3 times over the last 5 years. We've averaged over 90% for the last 7 years. So from a quality perspective, we've seen pretty good outcomes. But we wanted high quality at a manageable and sustainable cost growth. And what this slide would indicate is our trends typically are half or less of national trends, whether commercial or Medicaid. This year we've requested a 2.5% growth trend. We track fairly well, slightly down over the last 10 years as far as our appropriations as a percent of the total state appropriations. This bottom graph is one from a Pew report, and way to the right you see Tennessee way down there. And basically what it's saying is between 2000 and 2013, how did Medicaid track with the share of a state's own source revenue? Ideally, you're as close to that line as possible, meaning you're not growing at a pace that your state's own source revenue cannot keep pace. So I tell you all this to be able to say, we've come a long way. And before I get into the next slide, I want to hit a couple of things, and they're not always the popular things, but going from a completely failing program that we had in the 90s to one that is often regarded as one of the stronger, more solid programs in the country, there's some basic things you have to do. And I would tell you this is not unique to Medicaid, it's unique to business. If you have the average tenure of a Medicaid director right now, it's actually, we had said recently it was 17 months. It's actually less than that now with the latest news from my friend in Utah who is stepping down, who had a great deal of tenure. That's probably going to bring that average down even further. If you are going to have that type of turnover, which we did in our state, I'm the 11th director. The program's been around 21 years. I've been in this job for 9.5 years. 10 directors shared the other 10.5 years. And you get the outcomes during that period are tracked pretty well with that rapid turnover. So you need to invest in a team that can really manage a program that in most cases is a size of one of the largest companies in your state. So invest in the right people who can take these very complex programs and take them forward. Secondly, once you do that, then you can be more successful in the next several slides that I'm going to go over with you real quickly. This is a word cloud. I know it's called a word cloud because my 13-year-old daughter told me it was a word cloud, but basically just highlights a lot of different themes across the country that we see pretty regularly. We've consulted some 40 states across the country on a variety of different matters, and so we pick up on the themes that states are struggling with or that they're interested in trying to solve for. And so with that as a precursor, I don't expect you to read this slide with great specifics, but meaningful data is essential. You know, we have 3 key strategies that we approach everything within our organization. The first being simplify the complexity of the system. It's primarily because if I can describe something to you simply, I have a better chance of actually implementing it, but it's also easier for the consumers and others to understand our program. 2, it's better leverage our data assets. Government has historically been recreational data collectors. We get a lot of data. We just don't do much with it. And so trying to leverage those assets in a more effective manner is key to anything else we talk about with regards to different levers a state has at its disposal to keep costs under control. And then third, it's to better align the incentives in the program, and you heard a little bit of that discussed earlier, that is an area within healthcare that is ripe with opportunity. So first, investing in the right staff, and basically, and these are not always the great things that you do, press releases over, you know, and say, look what we did about like really building a robust data infrastructure. But if you don't have it, then you won't be doing any press releases, except for you're going to say, guess what, we had yet another year of double-digit trends. Again, basic blocking and tackling at the beginning is going to help you be successful for the long term. Without data, you wouldn't know who of this 15% of your disabled population is driving at least 42% of your costs. This is one of the Kaiser slides. So nationally, that tends to be the case. And it tracks fairly well whenever you get deeper into a state's experience, as you might imagine. And so without data, you could be working on a lot of different policies that are really not solving the problems that you have. And you may have heard in some other state they did this, and we hear this often. It's like, well, this state was doing this, so we're going to try that. Well, let me help you understand what problem they were trying to solve and how that isn't our issue. You have to have the data so you can focus your strategies in a way that's going to get an outcome that's meaningful. A lot of folks like to talk about doing things that, what about children? I mean, obviously in Medicaid, you care about children. I mean, we have 800,000 of our 1.5 million people that we cover are children. The issue is the majority of the time, children is not the thing that's driving you from a cost perspective. Obviously, you don't want to slide from an outcomes perspective there, and you do have children with chronic illness that you do need to focus on. But by and large, as a total population, that's not the area that's driving the majority of your cost. It's typically that 65 and above in your disabled population that spans the different age breakdown. Similar to the other map, you also want to think about if this is basically showing you where, and this is Tennessee data, but where our spend is going primarily. Again, if you were wanting to, as an agency and trying to get your program under control, do a lot around DME and supplies, which is way down here, then you're probably not going to see some dramatic savings. The majority of our money goes to hospital inpatient and outpatient. Emergency room care is obviously in there as well. Next, institutional care, which again tracks with the national figures, and prescription drugs. I feel remiss not having like 8 slides on prescription drugs with as many pharmaceutical reps that are in the room because I think they're probably feeling left out. But we have some things we can share on prescription drugs if that'd be helpful. This is just looking at the different diagnoses we have. Again, relevant for how you're targeting your strategies. You have to have data, though, to even know what you're talking about here, and what then you can implement action steps to help solve for that. So where are a lot of states going? You know, when they have data and they understand some of the problems that they're dealing with, and this is why, you know, the example I was giving about focusing on children, a lot of states, you know, do managed care, as this slide would show. I am a managed care supporter, obviously. Our state's 100% managed care and has been for 21 years. You have 39 states, including DC, that have gone down this route. The majority of the states, though, really have been stuck on just offering managed care for children and pregnant women, which, going back to my prior slides, are not the area where managed care is going to be of the greatest benefit. So it's good, and by all means, I think those folks, it's better to have managed care for children and pregnant women than unmanaged care. I'm just saying, if you're looking for where the greatest opportunity is, you have to look for your age-blind, disabled, and the elderly populations. So you're seeing more and more states move in this direction. And let me just say, cautionary tale. TennCare, when it started way back in 1994, it started from passage of the concept to implementation over 6 months. We went completely fee-for-service to 100% managed care in 6 months. Let me strongly recommend against doing that. It took us 10 years to fix the rocky foundation we built that on. And I know that talking to a lot of my peers across the country and some of the things they struggle with, there is this great interest in managed care. However, because you see the budgetary stress you're seeing as legislators, you're wanting to hurry up and quickly try to realize some of that savings. But I would encourage you, you may end up spending more than you thought because of the fact that you have to really put an infrastructure in place, and you have to be aware of the amount of time it takes to be able to transition a system to a complex managed care system. But managed care continues to evolve. I talk about there's this evolution that occurs within states, and you can kind of plot them out across the country. A lot of states will start out with managed care, like for their acute care, physical health services, start out for the populations like I was just describing, the pregnant women and the children, and then they evolve. They'll end up, okay, we're going to bring in the age blind and disabled from a population perspective. But then they also start bringing in behavioral health services. And then they'll start bringing in long-term services and supports, let's say for the elderly and the physically disabled. Then they eventually, progress to the intellectually disabled. There is this pattern, and it isn't it's not one that just happens by happenstance. It is because, as I described that evolution there, it gets more and more complex. You don't want to start at the end of that line that I just drew. Those are building blocks. You get that under your feet, then you can move to the next part of the area of your program to move into managed care. I should say this, that it's no surprise in our state we started out with everything kind of in managed care, then we pulled things out, then we put everything back in and more. And when you looked at it, and you hear this as a popular thing around the states, it's like, how do we better integrate physical and behavioral health services? And why is that relevant? It's because, imagine this, humans are we're complex things, organisms. We used to think that within our program, we could divide people's needs up into our nice little programs, only to find out that people's needs don't really work that way. It's kind of like when we used to draw service areas, and then we'd be surprised that people, when they needed services, didn't adhere to us, and they went to the next county over, and we're like, wait a minute, but we drew this really great service area. You're supposed to go over here. This is kind of the same thing as your programs, if you think about it, and I think as you look at state government generally, healthcare, within the healthcare line item, there's a lot of silos. And again, if you really look at it, the example I gave you the other day when I was speaking at an event is we had someone used to think that dual eligibles, people eligible for Medicare and Medicaid, were some of our most cost-effective, cheapest population to serve, because they were looking at their acute care services, and the cap rate we paid for them was very, very low. But then when you bring in long-term services and supports and pharmacy, oh my goodness, they're the most expensive population we cover. So yeah, you got to look at people in their entirety, but also break down those silos so that the care that they receive isn't this convoluted map that they have to try to figure out, but really that the system that you're designing is flexible enough to respond to their needs. And that's where we went to bringing everything within managed care, even more so than when we started out. But what you're starting to see is, then let's say that you did the perfect job of breaking down the cylinders of excellence within your healthcare realm. We're finding that people's needs are even more complex than just healthcare. And you talk to us healthcare folks, our hammer is like we'll give you a diagnosis and we'll treat you. And the reality is and it was referenced a little bit with some of the examples that Marilyn had. This is where you start getting into these social determinants of health, and you're starting to see even in the managed care realm, the managed care plans recognizing, whether that's a full-blown managed care organization or it's a ACO or, there's so many acronyms out there, but they're all variations of managed care. They're recognizing more and more these things that do not fit into the typical billing structure of healthcare really have an impact on our citizens' health and well-being. And, we had similar example about, we had this one individual who had 250 emergency room visits in a year. And there's no underlying health issues. And we do have a model where our care coordinators for our health plans go out into the communities, which that alone is great, but that's not the innovation. The innovation is empowering those healthcare workers to make decisions, those care coordinators to make decisions on their feet. And she was puzzled, there's this one care coordinator going to this lady, she was puzzled. She was like, no underlying health issues. She keeps going there. She goes, and she even would track her at the emergency room. She would be there, and she'd talk to some of the folks at the hospital, and it's like, yeah, she's great. She she asks us about her kids. She bakes us goods and everything. And so this care coordinator, out of her own pocket, and I love any time that our health plans are folks are taking money out of their own pocket to solve problems. But the wisdom that this one care coordinator had, she went to the humane society, bought the lady a cat. She hadn't been back to the emergency room yet. She was just lonely. I personally wouldn't have gotten her a cat. I'm a dog person, but the story is still relevant. That some of the things that you use to solve these problems are not the things that you or I would have thought would have been the thing to solve it. So having a system, if I had those managed care plans set up to where they're all losing money constantly, having that care coordinator, to be able to think on, to hire the right type of care coordinators that have that ability to think on their feet, but also paying that care coordinator enough to where they'll go buy a cat and some food for the cat, that wouldn't happen. So if you want creativity, you got to make sure that you're funding the program adequately. Next place where a lot of states are going, and again, it was touched on, so I'm not gonna belabor this, but it's getting at those perverse incentives in the healthcare system that I was describing is one of our strategic priorities, which is getting at how the incentives around payment are misaligned. And so, as you can see by the map, this is basically all the states that have different testing or designs of new payment delivery models across the country. I would say that this map does not represent, though, everything out there. I'd say there are even states that are not shaded red or blue that are also exploring different payment models. This is a continuum of different payment models, and again, I'm not going to hash this all out, but starting at the most basic, pay for performance, and going to a fully integrated, fully capitated model all the way to the top. Where we are is somewhere in the middle, and what we've done is we've looked at our program holistically and said, as we look at our patients, where all are we paying or incentivizing providers in a way that's counter to what we want to achieve? And let me just tell you, there wasn't any area in our program where there wasn't the perverse incentive. And so if you think about it, there's a lot of discussion about managed care, insurance companies, and the healthcare system in general. And a lot of people talk about, the healthcare, those prior authorizations the health plan puts on the stuff. It hinders my ability to practice as a provider. And don't disagree. That's added administrative hassles. I get it. But the system is set up this way because we're not rowing in the same direction. And so you have these health plans that are there to looking at the evidence, looking at all the research, which is voluminous, and saying that this isn't indicated as a first-line therapy, or this, you shouldn't try this until you try something else. And let me just tell you a personal story of my father. If that health insurance, in fact, the doctor told my father that he needed to thank the insurance company, because if they would have allowed them to do what was originally prescribed for my father, he probably wouldn't be here today, because they had prescribed a procedure that, as many people know about the steroid injections that were obviously tainted. A lot of people died and they lost their life. Well, that was right around the time period where they wanted to do that with my father, but it wasn't indicated in the literature as being the right next step. So there is this natural tension, and to the extent you can change how you're paying for the services to where everybody is looking at, as was described previously, at how to keep people healthy, how to make sure that we're using our funding most efficiently, then you see some of those tension moments between the providers and the health plans become more cooperative discussions about how we can achieve our common goal. I'm not going to go through all that, but I will stop on this slide for a minute. This just shows you, and this is a mock-up, but these little lines represent, for a particular episode, the variation that you see across the state. Now, this is a mock-up, but I will tell you we've done many episodes, and this is real. The exact same, and when you solve for the difficulties in the clientele and all these complicating factors, and you risk adjust for all that, you have wide variation about how we do the exact same thing. And so, as you would in any other area of the economy, you always want people to be the most efficient with the best outcomes. You don't want it to be a race to the bottom, but you want folks to be the most efficient with the best outcomes. The only way, or not, I shouldn't say the only way, but the problem is most of these folks, each one of those lines represent a provider. They don't know how they compare to their peers. And this is where we as state governments have not always done a good job about using the data we have and putting it in the hands of others so that they can be as good as we know they want to be. I've yet to meet a clinician that's not competitive. If they have the information, they tend to want to be the best. And so while we've done a good job of sharing our information back to the data point between us and the health plans effectively, we haven't always done that with providers. And so our goal is to start putting that data, and we've already started down this journey, putting that data in the hands of providers so that they would have actionable information, not just to say, here's how you compare to your peers, but here's where you're considered an outlier by the patients in your panel for inpatient, outpatient therapies, prescription drugs, so that they have a broader perspective and a roadmap on how they can be that top performing provider. What we would like is everyone to be a high performing provider, and I think our job in helping people accomplish that is providing this information, but also putting in incentives for those who are those top performers, that there's more resources that we will make available, and for those who are the outliers the other way, then there is some downside risk for that. So invest in your people, have data. If you're going to move, you have to manage your care, whether it's through MCOs or otherwise. Unmanaged care is not an option. Moving into a realm of where you're addressing some of the perverse incentives, and I'd tell you that the prime place is in the payment system. And let me just tell you, you can't do all those at once. So, looking at over a 5-year period of time of really trying to map this out.